If you didn't make it last night, not to worry. We kicked off with Dr. Rushan Mabiza, and he walked us through an incredible discussion on unraveling the history of abolition medicine and introducing us more so to a framework of why it is the right time to be speaking in this type of language. If you missed it, just to give you a quick recap, we've really carefully chosen the framework for the week. Abolition medicine means a lot of things, and to put it, I guess, as succinctly as possible before getting into today's presentation, it's most important that you know that abolition is an act of resistance. Abolition is an act of social justice and is an act of intentional unraveling of systems of oppression, of harm, of racism, of marginalization, of stigmatization, and that comes in many forms, especially within the body of medicine. So today we will be embarking on a two-pronged journey looking at racism in medicine. And I'm still going to keep my camera off.
You can turn it on if you like.
Okay, cool. Thanks. Hopefully you guys can see me now. Thank you again. Hi. And so this two-pronged conversation will begin today in this session that you're in right now. So thank you again for being present with us, where we look at race in clinical algorithms. And then later on this evening at 5 p.m. Eastern, we'll be kicking off with our second session of today, which will be the incredible Dr. Chase Anderson. He is an amazing child psychiatrist who focuses a lot on minority stress. So you don't want to miss it. And without further ado, let's talk a little bit about race in clinical algorithms. So this is a historical and contemplative toolkit, essentially. So what we're going to be doing today is talking through the history of how race even began to be included in clinical algorithms. What really are clinical algorithms, and why does it matter that they're not harmful? That discussion will be lengthy. You'll notice that the slide deck is a little bit lengthy. If you know me as a person, that will make sense. And then also it makes sense because this toolkit will be distributed to AMSA chapters, hopefully. And in that sense, it will be important that they are informed on, more than just bullet points, essentially, of what we're speaking about today. So Danya Madian, if you don't know me, I'm so happy to be serving as the AMSA Civic Science Fellow. In this role, I have had the pleasure of researching race and clinical algorithms, working closely with an incredible cluster of fellows who I will introduce here shortly, under the leadership of the Doris Duke Foundation and the wonderful Kimberly Lazak, who is not here with us right now, one of our preceptors who we deeply admire. I'm a big lover of quotes, and I think that they help us to centralize what we need to learn. And I'm opening up this discussion with this quote here by George Santayana: "Those who cannot remember the past are condemned to repeat it." What that means for me, and that can mean different things for all of us, right, is that there is a conscious and unconscious decoupling of sorts that needs to occur for us as future clinicians and as professionals in the field of medicine. We don't always intend to perpetuate harm, but we're not always aware of the practices that are long embedded in our curriculum that do just that. So where are we, without our consenting to practices of harm? Where can we find avenues within both our didactic years and our clinical years, which hopefully I can help to create a little pathway for here today? Where can we begin in those two separate parts of our training to even be aware of what questions to ask? How can we show up for patients in ways that we might not know they need us to show up to? So that's a little bit about what we'll be discussing today. So here is our wonderful cluster. You know me now at the American Medical Student Association, and we have the beautiful Indy at the Council of Medical Specialty Societies, Louis at the University's Allied for Essential Medicines, and Jyoti with the Association of Healthcare Journalists. I would like to take a second for Louis to say hi and introduce herself too, if she'd be willing.
Awesome. Thank you, Danya, and thank you for the time. So happy for everyone to be here today, and so happy for AMSA to do this. And I know Danya's put a lot of great work into this content. My name is Louie, pronoun she, her, hers. And as Danya said, we do this as a cluster within the Encoding Equity Coalition. I'm sure Danya will drop the link later, or it will be included as resources. I'm a part of UAM. It stands for Universities Allied for Essential Medicines. We are also working on this history of understanding the harms of race based medicine, also understanding the role of advocacy across the student organizations that we work with at UAM. Our organization is made up of students in medicine, social science, public health, and economics. And we really work globally to hopefully kind of reduce the harms of not just race based medicine, but really healthcare inequities. That's just a little bit about UAM, and I will throw it back to Danya for an awesome session. Thank y'all.
Thank you so much. The work that you have done, that each of our fellows have done, has been so important, and there are a lot of resources. So thank you for plugging that for us. And there's actually a landing page, guys, which we'll go through at the end. There's a landing page on the AMSA website where you can find more about this project, and it will include this updated slide deck. It'll include a list of references for the images and the content used in this presentation, including more about the Coalition for Encoding Equity and a lot of other resources, including some that I've created that I'm hoping I'll be able to have a chance to show you a little bit of today. And those ongoing materials will be uploaded onto that landing page. Some of this toolkit includes, of course, the slide deck, which is more so a crash course on clinical algorithms, and also looking at, again, materials that we can use from an advocacy perspective and conversation starters, if you will. So also, in the process of this conceptualization of our project, I've made a survey. So that is a link for the survey. It's a QR code. If you have not yet completed the survey, I just ask for us to pause for a moment for you to pull out your phones or well, that's really the device that will work for that, to scan the QR code, and it'll bring you to a landing page for the survey. And this survey has been carefully crafted to assess student understanding on racial bias and implicit bias, and it goes into a few multi-part sections to assess this understanding, to gauge our comfortability with discussing matters of race and racism with our students, our fellow students, with our peers, with our preceptors, with people in our schools, with our leaders, and also leave spaces for us to envision, have we had any training on this matter? If we haven't, what do we want? And if we have, what's been helpful? Already, I'm so grateful that I've received a little bit, around 60, I believe, a little bit under 60 responses. And in these responses, I've been carefully looking at the data that I've received, your feedback, and also the things that you're hoping to learn, a lot of which I have integrated into this presentation. So hopefully, if you did do the survey and you're watching this, you're happy that you'll see some of the things that you wanted to know about. Okay, so a little bit of a table of contents. And hopefully you had enough time to scan that QR code. This is just a baseline for us to look at what we'll be talking about today, kind of how the invention of racial hierarchy even came to exist, going all the way back to the Enlightenment period. The noise is coming from inside the house is more so a pun for, I shouldn't say a pun, it's not funny, for the body of medicine and the harm that we ourselves have perpetuated over the course of centuries. Now, transitioning into clinical algorithms, how can they be harmful? A few case discussions. How can we replace race with other indicators of holistic health? How can we really get to know the true nature of our patients and have those be the indices that we look for, essentially? Looking at some ethical frameworks for change. What does it mean if you're in clinicals and you're trying to navigate conversations that are difficult and you're seeing things that are upsetting? More resources and closing thoughts, and of course, gratitude. More to come. Okay, so quotes, moment of pause. I want to also mention there's several moments of pause throughout the course of this slide deck, and that was intentional because we're talking about some really, really heavy stuff. And in that, I want to create a space that is affirming, that hopefully is a little bit slower than how I'm talking now, that's intentional and that really gives as much as possible an uplifting of the lives that have been affected by harmful science. Um, I have been deeply emotional while creating this slide deck, and it doesn't feel like it'll do it justice today to go through it. Because how do you talk about people who have been harmed in the name of advancing science and do it like a casual presentation, right? It's impossible. So I want to hold space for emotions that might arise during the course of this presentation and while you continue to talk about these matters with your chapters. And I will always advocate that that is a space that is held in each of those conversations. So let us not ever forget that we're talking about people. Okay, so here we have activists, an activist and writer. Whiteness is a constantly shifting boundary separating those who are entitled to have certain privileges from those whose exploitation and vulnerability to violence is justified by their not being white. The course of this presentation talks about exactly that, the justification that white supremacy has given to allow for the violence to be perpetuated against Black people. So, as we get into the invention of racial hierarchy, how did this really come to be? Again, you'll be seeing a lot of words here, and I don't want to be reading from these slides, so I'm going to take you through more of a narration. The concept of race really evolved around the 1500s, simultaneously when we started using words like white, and with a tragic saddening, I bring the word slave to this presentation. These terms were infrequently used prior, right? So our understanding of race as a term was more so a way to talk about maybe shared ancestry or kinship or groups that were connected to one another in some way. It was not used as an indices to talk about a differentiation between people. So as that tool, as like linguistically, as this evolved, so we got lost somewhere along the line. So during the early 17th century, we had this Enlightenment period. And I truly think that the words Enlightenment are, even that is harmful and almost a funny way to word it, right? Because really what this period did is it brought forward, at least in the context of this discussion, a way to categorize and argue for natural laws that essentially claimed that white bodies were stronger, smarter, more capable, more able-bodied than non-whites. And these natural laws became slowly embedded into the way that various leaders spoke. And I go through that throughout the course of the presentation. But we have this essentially introduction that there are laws of the land, and those laws tell us that there's a difference between you and I. So how did this continue? We had this pseudoscientific legacy of sorts, right? Pseudoscience meaning not based in any fact or any science. We had perpetuators of this, including Thomas Jefferson, who published Notes on the State of Virginia. So in 1785, this document continued to claim that there was a difference in race and nature between whites and non-whites, introducing more so physiological distinctions between these groups and further identifying Blacks and whites as inherently different from conception. So obviously this was used as a tool to not only, and these words come up a lot, tool, justify, embed, right? Because it became an excuse essentially. And I use certain words on purpose today, like justify, right? Because these words and these harmful narratives became a way to say, well, it only makes sense, right, for us to violate the bodies of Black peoples because they are more capable of doing this hard labor and of, essentially giving their bodies than we are. And this is where things began to get extremely harmful, right? Enforcing forced labor due to this framework of understanding that this is what was safer for all. I'm going to continue to pause throughout this because it is very unsettling. Okay. So the noise is coming from inside the house, now taking us through how did we allow these narratives to then suddenly begin to emerge more and more into scientific arguments, right? So in the 1800s and 1900s, we started to see more and more arguments in science supporting and justifying, again, the idea that race was a biological construct. And I want to say again that while we see how this kind of first began, we start to understand that there was no scientific basis, right, to claim these theories. But because this was kind of the emergence of science as a whole in a lot of ways, they slowly were able to creep these ideas into to the framework that how we started, and therefore, of course, perpetuated over the course of time, unchecked largely for so long until, as I'll talk about today, recently, in recent years, we started to look a little bit more closely and started to reassess some of the algorithms and assessments that we use today. So again, looking at this distinction as an act of nature and excusing, right, the racial oppression that was occurring. So in the 18s and 20s and 1830s, you had Dr. Thomas Hamilton. So I go through the course of a few physicians here today. Dr. Hamilton committed awful crimes to many enslaved persons, including John Brown, who was an enslaved person who later fled from his plantation. And in his accounts, he describes, which I'll get into shortly, what his experience was like under the care of Dr. Hamilton, who had a belief that he was looking to prove that Black skin was thicker than white skin. And that harrowing belief began to be, again, a justification for scientific violence as he sought to prove his hypothesis. I want to mention here, and these are things that will also be resources on the landing page, that as early as 2022, there was a survey amongst medical students where they even asked the belief of Black skin being thicker than white skin. And a large majority of students, incoming M1s, first year medical students, had the false belief that Black skin was thicker. And I say that to say that even now we are dealing with these perpetuations, even if we see algorithms and assessments redacted, belief systems have long been damaged, and that is why this work is so important. I should be keeping track of time because your girl's talking. Okay. Okay. So coming to this quotation from John Brown himself, he published a autobiography shortly after he was able to flee, saying that Dr. Hamilton applied blisters to his hands, legs, and feet, which bear scars to this day, he said. He drew up the dark skin from between the upper and the under one. He used to blister me at intervals of about 2 weeks. This went on for 9 months until the doctor's experiments had so reduced me that I was useless in the field. I know this is difficult to read, it's difficult to say, but it's important. It's important that we know that this happened, and it's important that we face these difficult conversations. So, during this time, Hamilton continued to go through extreme lengths to prove his hypothesis regarding Black and white bodies, spreading delusions that were rooted in Thomas Jefferson's ideologies, rooted in other Enlightenment leaders, I use lightly, stating that these physiological differences were true, they were natural law, and they expanded from way more than the list that you'll see here. A few of them being smaller skulls, that Blacks had a higher tolerance for heat, that they were immune to illness, thicker skin, weaker lung capacities, impervious to pain. I use the word lies, and I introduced that in this slide on purpose. We talked about the importance of saying things as they are last night as well. It's not just a fallacy, it's not just a falsehood, it's a lie. And it's important that we call it that. And it's important that we understand that even though many clinicians and many students would never believe any of this, right? We cannot discount the power of these narratives being passed on and embedded in the curriculums that we were taught, that we're being taught. Physicians had a responsibility. We have a responsibility. They abandoned that trust. They abused that trust. They violated people in hopes of proving some type of argument that would, right, like the self-fulfilling prophecy would prove what their racist ideologies believed to be true. I also pause a few times during this presentation to say their names. It's important that we don't forget that we're talking about people, like I mentioned at the onset of this presentation. John Brown was a person. John Brown is one of many countless individuals who were harmed. And so this space will continue to be held as I speak today. I will be pausing as well throughout the conversation to check on everyone. Please feel free to unmute at any point if there's something that you'd like to share or anything that you'd like to put in the chat. I'll pause here. Is there anyone who would like to share anything that they're experiencing? No pressure. Okay. As we continue to delve into the deception surrounding all of the issues that we've been talking about today, we come to pain tolerance and the idea of being impervious to such pain. Dr. J. Marion Sims, who has been celebrated as the father of gynecology, began a self-fulfilling quest, if you will, to prove that due to the fact that he believed Black people were more able to withstand harsh levels of pain, that they would be the ones where he could practice his surgical procedures and perfect them in the name of science. So between 1845 and 1849, Sims would perform these operations. And this was before anesthesia. So these operations would be done completely without the assistance of medication and would torture young Black women, many of which were enslaved in Montgomery, Alabama. And this went unchecked because, again, in the name, quote unquote, of science, Sims was working to enhance our understanding of what surgeries could help to reduce mortality, could help to enhance patient outcomes. And so, unchecked he went. He was even named president of the American Medical Association in 1875 and in 1880 of the American Gynecological Association or Society. He actually helped to found that society. He had statues all over the country. And it wasn't until the past few years that we've seen riots around these statues, many of which have since been taken down. He went on to invent the vaginal speculum and the surgical technique in which he practiced on these wonderful women was to repair a vesiculovaginal fistula. And this is simply a complication, not simply, but a complication of childbirth. So where there's a tear that occurs between the uterus and the bladder for the mother. And in efforts to help provide a surgical intervention to support and to help women, Sims led an initiative which not only harmed and violated, but caused the deaths of many enslaved women who underwent repetitive procedures without consent. Inconceivable. These three women were widely known enslaved women who were affected by the procedures of Dr. Sim. Betsy, Lucy, and Archa. These women deserve for us to say their names. The women and men and gender fluid people who did not know yet what they would endure, names of which we will never know, accounts of which we will never hear. Say their names. The Society for Academic Specialists in General Obstetrics and Gynecology is now one of 23 organizations across the world that take part in designating a few days, the 28th here in February, which I thought was beautiful when I found this out, given that it is during Health Equity Week of Action here on Friday, and March 1st as days of formal remembrance. So I urge you this Friday and on March 1st to remember their names and all of the names in which we again will never know. Now to Dr. Samuel Cartwright. This background is extremely important as it allows us to orient to the procedures, as we discussed just now, assessment tools, which we'll continue to discuss today, and not only assessment tools like surveys and assessments like this, which are normally validated on white populations, but also tools like the spirometer, which we will go into, that consists of algorithms, which are, again, inherently race-based. So, Dr. Samuel Cartwright. Now, in 1851, after his publication, he continued to advance more lies that surrounded these differences being mostly on lung capacity. So Cartwright focused on, yes, natural laws, yes, supporting previous claims by Enlightenment leaders and Thomas Jefferson and other physicians who had claimed of these innate biological and physiological differences, yes. And he went more formally into his own quest to prove that lung capacity of Blacks was less, using this again as a justification to enable slavery and to enable forced labor, due to the fact that he believed this would vitalize the lungs and it would essentially correct for the deficient lung capacities that he was claiming existed. This image is cut off and there will be a better image for you on the website, but to validate his theory, Cartwright was one of the first physicians that really used what is now known as the spirometer. The spirometer was created in 1846 by physician Dr. John Hutchison. However, Cartwright used the spirometer, a tool used to measure lung capacity, and went on a quest again to prove that this deficiency was roughly 20%. So that meaning that Blacks, African Americans had a 20% less lung capacity than their white counterparts. This is where we hear the term race correction factor, meaning an embedded tool that uses race to say, if you are measuring this on a Black person, then it automatically will adjust differently than a white counterpart. This is still embedded in many spirometers today, and the capacity has been claimed. There's many different data points for this. And again, I want to reiterate for anyone who's recently joined the presentation or the live stream, that all of this is linked with citations and data, which all are on the landing page, which will be on the landing page. This capacity varies now in the reports today, but cohesively, we're seeing roughly 10 to 15% of a race correction factor still exists. The implications of this. I'm sure you can extrapolate what the implications of such horrible correction factors are. But to begin to name a few, we think of delaying or providing inaccurate diagnoses, not providing life-saving care, obviously reducing quality of life by a great margin, but also not providing care that could save a life. Meaning, how is the diagnosis going to be as valid for a white patient who is getting assessed for, let's say, COPD, right? Chronic obstructive pulmonary disease, versus their Black counterpart? How are we to ensure that we're not missing diagnoses because these race correction factors have been embedded for so long? We are, of course, missing them. Cartwright not only made claims of biological difference, but he made claims of psychiatric difference as well. He claimed that there was a disease of the mind, of which he coined drapetomania. And he believed that when enslaved persons were treated like family, treated as friends and like equals, that they would somehow forget the hierarchy in which they were meant to be obedient towards, and that then they would work to leave, they would flee. And in order to keep obedience and maintain obedience, he developed this idea that there was a diagnosis in which slave owners should be prepared for. As you can imagine, this further stigmatizes, marginalizes, right, every word that you can think of, enacting violence upon Black people. And statues of Sims and a Cartwright have been protested. His work now, there's quotes saying it reads like satire. No one would believe this now. It's not, unfortunately, true, because 150 years later, 200 years later, we might still be dealing with the fact that these fallacies are still embedded in a lot of the assessment tools in which we use today. Now, I will say, many of the ones that we look at have recently been looked at more closely, the ones that we'll look at today, but they still exist and they demand our attention, our honest attention. And let me say here, honest attention means uncomfortable truths, right? And many of us might not want to feel drawn towards those honest conversations because, of course, they're uncomfortable. And we don't want to perhaps stake claim that we had generations of ancestors who believed in something like this. But this is where privilege matters. Your voice matters. We have to speak up, and we have to let people know that we're not just going to erase the fact that this happened just because tools have been redacted now. Some tools. This is history, and history needs to be taught, right? So, another moment of pause to remember their stories. Essentially, the mere inquiry of race in clinical algorithms and tools, essentially, this embedment on its own, as we've talked about today, inherently allows a belief that there is biological difference, negating the fact that race is a social construct and not a biological construct, and thus weakens the care that we can give. So, let's talk more about algorithms. What exactly is this definition? And we've talked today a lot about why it's harmful. Algorithms are a set of rules, formulas intended to guide, inform clinical decision making. What does that mean, right? We'll talk today about a few measures like this, algorithms, but these formulas, such as with the spirometer, such as with glomerular function, which we'll talk about today, there are tools used to assess these clinically and guide from that point, from whatever data is retrieved from these tools, to guide the next steps that physicians make. And if those next steps have racism embedded within them, then even without maybe our conscious awareness, if we don't know these things, we are agents that are perpetuating that harm. That is, of course, the argument that I'm making today. So I already pretty much said that part, right? So problematic data is the issue here. Treatment recommendations that are formed, interventions that are suggested based upon data that is flawed. You don't have to be a researcher to know that that is scary. That's frightening for all of us. So this unfounded difference, as we know, has continued to go unchecked. And the introduction I want to make to us here now today is, where are social determinants of health, right? There are many other indices that we can use that help us to understand how this inequity even occurs. Indices that help us to understand people, their stories, their backgrounds, their trauma, using trauma as an indices too, their diagnoses from their past. How do we ensure tools are comprehensive? If one of 4 questions being asked is what is the patient's race and not one of these other options, what are we consenting to? Aletha Maybank states, she's an advocate and a physician, just as policies can be racist, so can algorithms. They are both sets of rules that help determine how resources are allocated. Disparate impact is the main consideration in whether an algorithm is racist. The initial question being asked, the inputs that are used, the way the instructions or the calculations are constructed, and by who? And who is interpreting the outputs? And in what context are they? All of this can contribute to more or less equity. It's not exactly read from there, but you get the point. So we'll go into some discussions on particular tools, but I want to pause here and ask a question. What happens when the very mechanisms created to inform and guide us are the exact same tools that are used to create harm, racism, oppression, ones that go against the oath that we took, the first oath, the most popular oath, the most famous oath, to do no harm? I'd love to hear from anyone who's willing to respond to this. I know it's a big question. That's okay. We also have the chat if anyone feels called.
Hi. I think one of the biggest challenge, like when we think of do no harm, we're thinking of just us actively, not like trying not to harm our patient, but we don't think about ways that we are participating in harming our patients. For example, like, when you were talking about the oximeter, and I was thinking about COVID, for example, during COVID, like we know that that disproportionately really affected people of color. And there's been research before COVID that shows that the oximeter overestimates oxygen saturation in darker skin tone people, right? So now with that knowledge as a physician, instead of using that data to support why you're not giving what, being aware of that and then tailoring your care to that knowledge rather than just saying, okay, well, this is what the oximeter is saying, so that's what I'm going to go by. But taking that extra step and really evaluating and taking into account other circumstances to make a good clinical decision. So I think that's that is hard because you're only thinking about, okay, well, I'm going by what I've been taught, but also knowing that some of the things that we've been taught is also embedded in racism. So yeah.
Thank you so much for sharing that. Thank you so much. And you're absolutely right. And what a perfect and timely example that you gave. And, not only what a perfect and timely example in the ways that you're making it relatable, right? Because it's happening, it was happening now just a few years ago when we were struck by COVID in 2020. And then also you mentioned something that really stuck out to me about, you as a clinician, you're just going by what it's showing, right? And in your mind as a clinician, you want to provide the highest level of care. If you're not informed on this data, on this research, on these findings, then of course you'll just say without even realizing it, okay, this is what I'm reading, these are the recommendations I'm going to make. And that is the argument, right, for the unconscious participation in that cycle of harm.
Correct. Yes.
Thank you so much. Are you a medical student? Do you mind if I ask, or in clinicals or pre-med?
Yes, I'm a medical student.
That's wonderful. Have you seen this in clinicals yet?
Not yet.
Okay, we'll keep our eyes peeled, won't we? Thank you so much for sharing. Is there anyone else that felt so inclined to share a personal anecdote or something they've noticed, something that they're feeling in response to this? Okay, we'll continue for now. So now we go through a few cases here today, and in the efforts of time, or with time in mind, I won't go obviously too deep into everyone, but I do want to ensure that we are aware of a few that have much data supporting their race-based ideologies. So for example, looking at vaginal birth after cesarean computations. So the VBAC is a tool that is used everywhere to essentially determine success rates for vaginal birth among women who had already had a cesarean delivery. And you can see here on the right-hand side what the calculator kind of looked like. And it still exists today. And actually, a part of the toolkit will include a modern day calculator for you to see. But these were some of the I let someone in the chat, sorry. These are some of the indices that were asked when a clinician would place their patient data into the calculator, right? So I'll pause for this and come back to the fact that nationally, Black women remain 3 to 4 times more likely to die from pregnancy-related causes. We spoke about this last night when we discussed the framework and introduction to abolitionist medicine. And what does that even mean? And then we use the example, depending on which breakout room you were in, we use the example of the mortality of Black women during childbirth and asking ourselves, what does an abolitionist framework, what we're talking about here today as well, look like in response to an inequity like this? How is it possible that these numbers could be so different? That should raise our attention and raise our voices, which it has, thankfully. Now, the race-based calculations, as you can see in the image, it asks you if the patient is African American or Hispanic. 2 race-based correction factors, as I mentioned earlier, similar to the spirometer, similar to many other mechanisms that we'll talk about today and many more. These correction factors inherently are asked as one of the very few things in an algorithm or in a calculation, and are then immediately embedded with differentials that get put into the computation and changes the outcome of the data based upon those questions. So, as you can see here, an example of women of identical age, identical height, identical weight, identical BMIs, which I think BMIs are problematic. Anyways, we want to talk about that today. Identical previous vaginal deliveries or vaginal delivery since a cesarean, right? So almost an identical chart, with the only difference being, is the patient African American in this calculation? On the farther right-hand side, we see the vaginal birth after cesarean computation, the predicted chance, and the confidence interval. It speaks for itself, the difference between a 48.2% versus a 64.5% in a white woman counterpart. What does this mean, right? This means that clinical recommendations based upon this data might lead a physician to saying, well, let's actually do standardized surgery. Let's not do another cesarean. Let's not risk this, right? But that in and of itself could be the risk that's greater that ends up putting that mother at risk of bleeding, of death, of hemorrhage. But we were dealing with flawed data. And how is a physician, if they are not equipped to know this, how are they then participating in harm by the recommendations that they're feeling? Of course they will make, right? Similar to the pulse oximeter that we spoke about a moment ago, right? Rebecca Israel Cross, who studies this work, states that people of color, especially Black birthing people, are given unnecessary C-sections more often than white people. So to include race in the calculation not only normalizes the disparity, it actually perpetuates it if practitioners are using such tools to determine whether or not a woman is eligible to deliver vaginally. We'll review a few other cases here today, such as estimated glomerular filtration. So GFR, if you've heard of it, is a measure that is used to estimate kidney function. There's various levels to assessing kidney function, and obviously we don't need to go too in depth here today with that. However, this information is important in understanding why these indices matter, right? But due to the expenses of these examinations, creatinine is used as a filtration marker to essentially estimate GFR using these tools. So these tools will also be linked in the toolkit and in the landing page for you to read over. Essentially, they stand for epidemiological tools that were created to give a mark of sorts, to give us an idea of the function of that person's kidney. And they utilize age, sex, and race as adjustments, or they did for a long time. You can see here the timeline beginning back in 1976, the faulty kidney algorithm that was developed based upon data that was inherently faulty, moving towards how research was showing these inequities existed, but they continued to use this algorithm until we had a call for the removal. Looking at how long went and goes between introduction of these algorithms and response to change is what is frightening and what demands us to have knowledge regarding these issues. Similarly to the other calculations we've discussed today, there's no accountability for social factors in a lot of these calculations. We're not looking at predictors like diabetes or hypertension as often. I'm not saying that all of them do this, right? But there are formulas that are not taking into account a comprehensive patient story. Social determinants of health, something we'll continue to talk about today, include access to resources. And like I mentioned earlier, trauma. If a patient is more exposed to violence in their neighborhood or lack of access to healthy foods, if they're even able to have transportation to get to the doctor's office, if they feel they have a lack of social support, I mean, there are so many indices that matter when making recommendations for care. So I mentioned here when the flawed studies kind of came to be, what these incidental findings caused for us to report. And now, yes, there have been revisions that have been made in 2021, But this is a part of our medical curriculum that many clinicians prior to 2021, right, that were trained. I mean, and it's not like we're getting taught this necessarily. I don't know about each of you, but I wasn't taught this in my didactic years, my first 2 years of classroom studies. And there are many students that have been trained and clinicians that have gone through rotations that were not informed of these things and have treated patients with this understanding. This goes through here, the stages of chronic kidney disease, which glomerular filtration, the estimation of glomerular filtration rate uses to identify patients at risk for chronic kidney disease. The table discusses the 5 stages typically of kidney function and health. One, of course, being a healthy kidney and leveling all the way to stage 5. And when a patient reaches kidney failure, they are, of course, recommended for things like dialysis, which will help support the patient due to their lack of function. Now, the race indices, the race correction factors previously accounted for roughly an 18 to a 16% increase depending on the tool in eGFR, so in the estimated glomerular filtration rate. So what does that mean? So essentially, clinicians might fail and did fail to diagnose earlier cases of chronic kidney disease, or even just semi-abnormal, kidney function, or a slight loss of moderate or growing to severe loss of kidney function, because inherently the eGFR was telling them that the kidney function was higher than it really was. Black patients account for over 35% of all patients in the US that receive dialysis. So when patients are not diagnosed early, when patients lose time, they can lose their lives. And that's why studying these things matter, especially for us. I want to pause here. I do a lot of talking in this presentation, so I'd like to just take a moment before I continue and ask if there are any questions or anything that anyone would like to share. Okay, so moving into psychiatric diagnoses, it's important that we're also aware of how this shows up. Most often in the literature right now, we're seeing schizophrenia and psychosis and psychotic disorders that are either misdiagnosed due to these race correction factors, or also are completely missed and are not only diagnosed as something else, but these patients are in stressful, traumatic environments that are predisposing them to developing psychosis, and they're not being assessed properly. Now, this slide talks more about the larger likelihood, right? So Black individuals roughly 2.4 times more likely to receive a diagnosis. However, what's also important that's not in this slide deck to note is that they might be receiving this diagnosis and missing the inherent root cause of why this psychosis is happening. They might miss that the trauma that is occurring to this person due to decades and years of distrust. What is really happening here, essentially, that's bringing us to a diagnosis so strong without maybe the proper evidence? So structured assessments that are validated tools. So this is a longer discussion that, don't worry, there will be many conversations for if you're interested. I know that I deeply am, and things like the Beck Depression Inventory and many other assessments that are standardized, but were historically standardized on samples of white persons. And due to this, the tools went, similar to many other equations and algorithms and assessments that we use, unchecked. How is it that we can use a tool only validated on one group and not account for that cultural sensitivity? Assessments lack an understanding of social determinants of health. But again, we're here. And many assessment tools, even to this day, within the field of psychiatry, will not ask about the violence, aggression, stigmatization, sense of social support etc., which this graph is cut off on purpose for you guys to just show schizophrenia and bipolar and the interlap between lack of access to care and misdiagnosis in the same patients, whether in a white or black counterpart, showing that the lack of access to this care and the misdiagnosis is disproportionately occurring in these communities. In the survey that I created, one result that I found really important to note was that there was a drop-down menu, if you haven't taken it yet, that assesses understanding of social determinants of health in relation to a diagnosis. And there are things like violence, aggression, stigmatization, marginalization, access to social support, faith, etc., listed as indices. By and large, many students have chosen that they did not believe that maybe some of these determinants were as harmful as some others. Now, and this is so important for us, and I think it breeds discussion around the fact that discussion, how many times can I say discussion? That for us is so important to know that if we believe that social determinants of someone's health, like all of these aspects of their day-to-day life and what they're exposed to, don't matter as much as biological indices, then we're losing half of the conversation. And this is actually reported by and large on many of the assessment tools, like the ones I mentioned at the onset of today, back in 2020, when there was a large assessment done of incoming medical students. We often see results like this. It begs the question of why. So a big, I would say, for me, a takeaway for this entire conversation is how decades of trauma, decades of violence, decades of oppression, decades of racism leads to distrust, leads to uneasiness, leads to anxiety. And this is not a validated, tool that I'm mentioning here. This is just a concept, a framework that I'm introducing, that I'm asking your thoughts on. That this then leads to poor health outcomes. A trauma-induced health deterioration of sorts. How do we, when we don't know what we don't know, how are we harming and violating groups that need us? And then blaming poor health outcomes on those very groups. I'd like to take another moment for any reflections on this question.
Hi, Donya. Can you hear me?
I can.
Hi. I just want to say thank you for bringing that up because especially in the Black community, it is a very, it is a huge thing. And I see it manifested in my own family, from things that my grandmother has said to things that have been passed down from her mom. And what we're finding in the Black community is that they'll wait till the last minute until they're literally almost on their deathbed. And you'll see that the ERs are becoming overwhelmed with all these patients with comorbidities. And it's making the healthcare system that much more complex because they have a mistrust and then it manifests in different ways. So I just want to say thank you for bringing that up because it is important to identify that that is the case that has showed up in our community. So I just want to say thank you.
Thank you so much, Stephanie. Thank you so, so much. Thank you for saying that. And, it hurts my heart, to hear that, but it's the truth that we need to hear. And so thank you for everyone's, bravery and courage who have been speaking today, and everyone who's here too. It's okay if you're not feeling comfortable to speak, but many times we don't look at why distrust could be present. Stephanie, like you mentioned, like If that is there, why is that there? Why is it that they might wait until they feel they're on their deathbed, and they might wait until their symptoms are so severe that there is no possible other avenue than going to the ER or going to see a doctor? Why is it that that is the last resort instead of the sacred haven that medicine is supposed to be? It didn't happen by accident, right? And the more that we blame communities of color for their response, for their very reasonable and, in fact, normal, healthy response to decades of violence, the more that we criminalize and make them feel other than due to this response, and then again blame poor health outcomes on the fact that they're not coming to us, the more we're missing the point. So thank you. Does anyone else have any reflections for us? Thank you. So, what do we do? Well, that's a big question, and one that, of course, we can't answer in one session here today. But I will speak about the movement. How do we replace race with indicators of holistic health, of social determinants of health? How do we give the narration back to the people who matter most to tell their own stories? So we see here some movement makers like W.E.B. Du Bois, Kelly Miller, advocates that led to institutions like the Black Panther Party in 1971, all of these people that began to expose racial bias. Then things like the Black Lives Matter movement, still strong today, and the tragic death of George Floyd that really brought new attention. And I want to hold space for a moment in the fact that it should never take a death, a violent death, a death at all, to engage us. And George Floyd's story, has been celebrated as a hero who now is, this person who began this newfound socio-political movement. And yes, and also let us not forget that he died at the hands of police brutality. And that should have never happened. And so as we examine these structures and as we celebrate progress, how do we come up with different solutions? Now, abolitionist medicine, like we're discussing, and like we discussed last night, talks about these innovative solutions. That noise coming from inside of the house may not want to listen to the noise coming from the outside of the house, right? That doesn't mean that you shut up. We find ways to integrate more innovative indicators, and we back them up with data, and we communicate them bravely, and we find ways to feel safe in community, and we argue for things to be redacted and for things to be replaced by things that make sense. A lot of what we have been seeing already. So a rising number of clinicians are beginning to ask these questions. We're no longer comfortable with the idea that there are norms and that these norms have gone unchecked for so long that now, as we begin to see movement in the right direction, it begs us the question of how do we, beginning right now, orient ourselves as medical students, and if there are clinicians here in the room, how do we orient ourselves, and watching in stream, thank you those on stream, how do we orient ourselves to respond thoughtfully but firmly? There is a term that the amazing Brene Brown, if you're not familiar with her, look her up, please. She says, strong back, open front. So staying firm in your beliefs and in what you're fighting for, but with an open, loving heart. If you're familiar with some of what AMSA has been doing with the Code Blue initiative, which I want to just mention right now because it's so important and it relates to this discussion. This Code Blue was sent out as a lighthouse messaging to call other students, clinicians that feel like us, that want community, that want a sacred space to land, a safe harbor against the unknown, murky, scary, frightening waters, and sometimes the still waters. Whatever those waters look like, the safe harbor exists. AMSA is working to be that place. And as AMSA works to be that place, it's our responsibility to help you feel as comfortable as possible leaning into your values, because medicine, of course, due to its inherent harm in many ways, will work to bring those values, shift them to the side at times. So how do we engage our voice? How do we continue to have difficult conversations that lead us closer to acting within our values as we continue to treat or begin to treat others? So over time, we have, of course, begun to understand that race is a social construct, that racism should be taught in medical curriculum, in schools, in clinical rotations. We have moved largely away in some ways from this rigid categorization, and we are seeing social determinants of health being taken more seriously. But it still happens, and it's still embedded in the history of many of these tools and in many of these assessments and these algorithms and these formulas and synonym. So how do we keep responding? They're antiquated, they're harmful, and it's up to us. I love this figure. It's not, as pretty as some of the rest of the ones, but I think it really speaks to what's important here. I'll walk us through it. For those who are maybe on the streamcast, it might be a little bit blurry, but race was invented, it says, as a term to codify racism and white supremacy. Race then upholds that socio-political hierarchy that we spoke of today, that there are innate biological, physiological differences between groups. We see then that racial inequity occurs across all institutions and, of course, across the body of medicine. Racial inequities are happening, are occurring, springing forward, springing up, and yet race and not racism was being studied, has been studied. A theme of this week for Health Equity Week of Action within the framework of abolition is just that. Inequity doesn't just occur, and if we spend too long simply studying the inequity and not studying the root causes of how the inequities came to even be, then we're again missing the mark. The goal of HEWA and the goal of AMSA in many ways within this type of framework is to teach, educate, equip, embolden you to look at what needs to be looked at, to look at a social construct of race, to unlearn racism versus race, or is it to learn racism versus race, and to unlearn race, to promote transparency, to ask difficult questions, to assess your clinical sites, to see what might be occurring, to ensure that there is awareness around how certain results that you're seeing being attributed to certain diagnoses are even coming to be. That's hard. Asking those questions is hard. And it's easy for me to say as a student who's not yet in clinicals, and I recognize the, how funny that might seem. And so I also urge clinicians to continue to educate us on what works best, because we need everyone at this table. We have to keep assessing. The Council of Medical Specialty Societies states this: this disconnect allows scientists, doctors, and other medical providers, and those training to fill their positions in the future, us, many of us, to ignore their own complicity in healthcare inequality and gloss over the internalized racism and both conscious and unconscious bias that drive them to go against their very oath to do no harm. This might be one of my favorite quotes, and I speak a lot throughout the toolkit about conscious and unconscious, and I spoke about that earlier here today. Many of us are unconscious of some of these practices. We're not looking to blame, shame, and criticize. We're looking to criticize some things, but we're looking more so to embolden again and to bring to conscious awareness the practices that have occurred over centuries and to give you a safe landing space to begin to fathom how we can face these things together. Our oath to do no harm is the first oath that we give, and it's the one that we should upkeep at all costs. So, another superfluous graph for you. As we come more towards the end of today's session, and thank you if you've been here the whole time. I know we've gone slightly over, which again, if you know me, you probably had in mind would happen. What do we do for an ethical framework? This tool that I have right here on the right-hand side is something that I have am beginning to create. It's one of many tools that exist, and it's just one of my suggestions for how we can begin to create an ethical framework that reconsiders how we have been taught. It's important that we use trauma-informed language, which in fact means abolitionists, and it means we are looking at this through a lens of truth, through a lens that necessitates honesty and vulnerability. When we first begin didactics, it's urging that our curriculum has a socio-ecological, an anthropological view. Something that we're working on, and my toolkit is working on, is introducing some of these curriculum suggestions, I just made a word, suggestions, into curriculum, and asking how can we, and in a lot of ways, this is what AMSA does through our Scholars Program, which I will plug now. Our Scholars Academy, our AMSA Academy, does a great and wonderful job of teaching on topics that are not taught typically in our medical school curriculum for a lot. And in a lot of ways, a lot of the feedback that we receive from curriculum directors are that there's no time, and we have to focus on the most important things for the step 1 exams, step 2 exams. And while we understand that, it's also important that things are taught thoughtfully, and that as we are training future clinicians, they are understanding in whatever capacity possible how a lot of this history and the treatment of certain communities have been throughout the course of time. It makes a difference. And it can be in both longer forms like whole classes or smaller forms like instructors ensuring that they emphasize this in their teaching. So how do we inform the unconscious and the unconscious factors? How do we confront? How do we set intervals to think through what we're learning? This framework walks through 6 steps, looking at the body of medicine, how it impacts quality of care, looking at building awareness through education that is based on history, the real history of racialized medicine, adopting trauma-informed responses that prioritize understandings of generational oppression, that prioritizes an understanding that distrust happens for a very true and reasonable and healthy way. People distrust when they have a reason to, most often. And that is a form of protection of themselves and their loved ones against future harm. So the next time there is a patient in front of us one day, God willing, and the next time we're learning about patients and we're learning that, oh, they were medically non-compliant or not adherent to their plans, how can we question what might have happened here to this person? What are the other possibilities that could be in this person's story? And then we need more research. We need funded research, which is obviously on the line right now given the current climate. We need funded research with innovative solutions, including social determinants of health, including an emphasis on trauma. We have to bring trauma into the picture. The medical and the psychological are one. The biological and the socioeconomic are one. We need data, more data that talks about that. We need assessments that talk through that lens, and we need to implement and monitor and be consistently ethical and justice-minded. I think that was supposed to say justice-minded evaluation. Bravely proclaiming and repeating. This might be the last quote, but I don't promise it, by the lovely Khadija. It's important for us to consider how algorithms are expanding and building structures that can be oppressive. We might be able to remove race or use a different algorithm, but what structures of discrimination, marginalization, or oppression do these algorithms leave in their wake? We study this in our fellowship, and one of my lovely fellow members, Jyoti, has brought this into our focus for us to talk about today, which is, yes, let's remove it, but let's be careful about what indices we're using to replace, or to what indices we're using to introduce a new system, an ethical system of change. And is that new indice really more ethical, really more justice-minded? How do we ensure of that? How do we ensure we're not replacing one violent, oppressive act with another? Check the chat here. Okay. So we are going to end here closely. I lost track of time. So this will be a set of resources. I'm going to allow you to move through them. I'm going to place them on the landing page. They include some that I've created myself, like today, and also a preceptor and student navigating difficult conversations framework that hopefully will be of assistance. These resources will be ongoing, and they will be places for you to land, places for you to look through, for your eyes, for your ears, for your heart. Hopefully things that you can lean on through the further development of this toolkit and of my fellowship. We must do better. And I want to thank you and express gratitude for your time today. I want to also, as I open it up, I want to first thank you all so much again for your listening for so long. And I'd love to just open up the floor, and maybe first to the lovely Louie, my fellow who has some closing thoughts for us too about her work. Thank you so much.
Yeah, I love that, Danya. Like, I think the only closing thoughts I have are just that you were so intentional, so transparent, so truthful about these uncomfortable conversations that we need to have. And I think you just brought a lot of great limelight into the history as well as into the current practice and hopefully the future training for a lot of physicians when it comes to these race-based issues in healthcare. So just kudos to you and of course everyone in our Encoding Equity cluster. And yeah, really engaging presentation. So great job.
Thank you so much, Louie. That's so kind. And, you know, it's easy for you to say you've created such an amazing toolkit as well. And I hope that I'd love to spotlight that too. So that will be a part of our landing page with your consent. And of course, feel free to add anything that you'd like in the chat if you're comfortable, but no pressure. Just everyone know that the work of our fellows, Jyoti, Louie, Indy has been so powerful as well, and we'll continue to share that work. Thank you guys so much. Is there any other closing thoughts, questions, concerns? I'd love to hear them. No pressure. Thank you all so much for your time, for your energy. Thank you for being a safe place for us to land. And we'll see you here shortly. Actually, the next session will be beginning here at 5 Eastern, which is in 6 minutes, with the lovely Dr. Chase Anderson, child psychiatrist and minority stress expert. Join us while we continue to